Hi guys, I think we can start. Today we have Dr. Hernandez with us. He's one of the assistant professors in medicine attending Montana West, and he was our beloved resident and chief resident a couple of years ago. So thank you, Dr. Hernandez, for your time, and we can start whenever you prefer.
Can you guys hear me?
Yeah.
Yep. Perfect. Thank you, Chiefs, for inviting me to help out with the presentation. So today, I just wanted to do a short talk about how to approach the admission with cellulitis, which is something that we commonly get here in the hospital, and we're going to do it with 3 cases. And I'm going to ask for your help. Like after each case, we're going to go over a few questions, and I'll ask for the chief's help because I've worked with a bunch of you, but not the majority of you. So the chiefs will help me pick on people. I know, let me see. I know Tom. I like your mustache. Hey. Who else have I worked with? I see Prab, Shelby. Great. So briefly, we'll go over three cases of cellulitis. I'm hoping that we can get over the cases quickly. After each of the cases, we'll have a few questions and that you will help me answer. And the topic, the 3 things that I want to focus on, and when you see a patient that's admitted for cellulitis, the first 24, 48 hours of the admission to establish a diagnosis. Then once you've diagnosed cellulitis, how do you choose the antibiotic treatment? And then some special situations that we can face or when to be concerned. So as a brief introduction, I don't think I have to go over any of this. As we know, skin and soft tissue infections are very variable. So they can go from just a simple folliculitis to like a neck flush and patients going to the OR. So there's a big spectrum, and it's our job to decide like where in the spectrum our patient falls and how severe their disease is and treat them appropriately. So are you able to see my pointer? Yes, I think so. So as you can see here, cellulitis and erysipelas involved the dermis, and then necrotizing fasciitis extends beyond the subcute fat to the fascia. Broadly, and we're going to come back to this, we classify them clinically in 2 types, purulent and non-purulent cellulitis. This classification is helpful for many reasons. It helps us clinically to determine which bacteria is most likely causing the infection. It guides us on how to treat and how to assess the progress. So let's get started. We're going to do our first case. You're going to be seeing a lot of red legs. So this is the first case. This is the patient that you get in the ED, and as you can see, probably the left leg, and I can come back. So he's a 71-year-old male, AFib, hypertension, heart failure, chronic lower extremity DVTs. So he already has some chronic venous insufficiency as well, gout. He was brought due to a fall from a chair at Port Authority, and he hit his head. Just so you guys know, all these cases are from here, cases that in our team we took care of here in the hospital, and interestingly in non-teaching mostly. but they like outline interesting points. He complains of bilateral pain in his feet, burning sensation on the plantar aspect of his feet when he walks. At home, he takes gabapentin, a very high dose for severe pain, denies any numbness and tingling. He has a history of chronic ulcers and swelling in his bilateral lower extremity limbs, and he follows with vascular surgery. And because he had DVTs bilaterally, he was diagnosed with post-phlebitic syndrome, and he had long-standing swelling, redness of his lower extremities, some pain, desquamation. So he had some chronic changes. So a closer look here, the left leg looks a little bit more red, but the right leg has the skin is not normal. And this is a closer look to the right foot over here. Yep, and he's admitted to medicine for cellulitis. His vitals are okay. He's not febrile. He's WBC 7.6. He did get a ultrasound Doppler. It was negative, and he was started on cefazolin. He was admitted to medicine for cellulitis. If this case sounds familiar, it's not a coincidence. It's a very common admission diagnosis. So questions here, and I will ask you, Julia, to ask any of the interns. So I think one each is probably the most fair.
Okay.
So the first person, what are the risk factors for cellulitis?
I can see Neha. Can you help us out?
Sure. I mean, uncontrolled diabetes is one of the risk factors for cellulitis.
Yep.
Anything else that comes to mind?
I mean, sometimes I've seen in heart failure patients who have stasis dermatitis, they also are at increased risk of cellulitis.
Yep. Edema, for sure.
Edema, any form of edema, correct?
Yep. Anything else? Anyone else can help, or if you want to type them in the chat as well. But
Yeah, guys, feel free to jump in. Murillo, do you have any other ideas? Someone says, Tom says, poor circulation, venous or arterial.
Chronic venous insufficiency.
Mhm.
I think that could be associated with cellulitis.
I see that IV drug use, open wound. Mhm. Yep. Anything else? Yep. Yep. Those are great answers. Immunocompromise. Mhm. Yep. What do you guys think about age and weight? Do they predispose you? Is there any
elderly age, obese patients? Yeah.
Yep, obesity and elderly, absolutely, the two important risk factors. Yep, and then we can go to the second question. If you want to help me picking someone, Julia.
Yeah.
So, what are the clinical characteristics of cellulitis? Like, how does it look clinically, and lab and
Bailey, can you help us out?
Yeah, sure. Sorry, my dishwasher's running, so it's a little bit loud. But I guess edema, erythema, warmth, those are the things that I would say.
Yeah.
Those are the three major ones.
Yep, edema, erythema, warmth. What do you think about systemic symptoms? Can there be systemic symptoms accompanying the cellulitis?
Like sometimes if it's advanced, you'll have like a white count, but that's if it goes untreated, like possibly be febrile.
Yep, absolutely. Anything else? Anyone else would like to add on to that, to the chat?
Jen? Oh, someone says duration.
Duration. Yep. Pain. Yep, for sure. poorly demarcated erythema, and then Dio is adding a little bit of the systemic symptoms, so tachycardia. They can have fevers. What about the time course of the disease? Like, does it present over days? Does it present over weeks, months? What do you guys think?
They're saying days.
So it presents over days. So that's one thing that it's, if you carefully ask the patients, like, how long has this been going on? Cellulitis is typically days. So this happened within a week, got very red, got very swollen, tender, and plus minus systemic symptoms. Yep. And then the third question for someone else, which clinical features should make you suspect an alternative diagnosis? And I think that,
Yeah. Anyone who wants to answer this question?
Bilateral by Sarah Luby. Joint pain, because it would point towards calf tenderness. Yep. Pain out of proportion of the clinical exam. Great. And if you can add, when you add the symptom, what do you think of? Because I'm seeing this here. Crepitus makes you think of loss of pulses. Those, all of them are great. Yep. Sharply demarcated erysipelas. History of insect bite, recent new drug use. Yep. Palpable mass or fluctuance suggesting an abscess. Neck fash. Yep, yep, yep. Excellent. Very good. Thank you, everyone. And I think that you guys pretty much know this. You did a great job. So in terms of risk factors, there's a lot, and I think we got most of them. So a previous attack of cellulitis, it's a risk factor. Older age, obesity, homelessness, venous insufficiency, as we see very commonly. Interestingly, we see a lot of patients that go for cabbage over at Morningside. So the patients that have the saphenous vein grafted for cabbage, edema, someone mentioned in patients that have congestive heart failure or cirrhosis and they have lower extremity edema, they have a higher risk for having cellulitis. And the one essential thing besides all these risk factors is that you need a disruption of the skin. You need anything, either trauma, an ulcer, an inflammatory disease, mycosis, like tinea, for the bacteria to go in the skin and cause the inflammatory process. So once first attack of cellulitis can predispose you to a next one up to 20% of cases. So it's important to ask the patients if they had previous attacks of cellulitis. So diagnosing it should be pretty straightforward. However, is actually not as simple. So there's been some recent studies, small studies, saying that a lot of patients that we admit to the ED and that are red leg, quote unquote, and that are cellulitis, up to 30% are misdiagnosed, which means that they come into the hospital and they actually don't have cellulitis. And 85% didn't need hospitalization, which is a lot. So if there's a patient that you can avoid admitting to the hospital and exposing them to the hospital, that's great. And 92% received unnecessary antibiotics. So it's this term called pseudocellulitis, which is a broad term that encompasses inflammatory and non-inflammatory problems that can look like cellulitis. and there's a bunch of them. So the most important ones, and I'm going to touch up on 3. So stasis dermatitis, just because it's the most common one. So if you get an admission for bilateral cellulitis, most likely it's just stasis dermatitis. Most of the bilateral cellulitis that we see, this is the most common diagnosis. Then I think DVT, we are very good at distinguishing and suspecting a DVT. Another one that I would like to just briefly touch upon, because I think we don't think about it as often, and it should be considered, is this lipodermatosclerosis, because in the acute phase, it can be painful, erythematous, it can have edema, warmth, and those are all the symptoms of cellulitis. So it can really look like cellulitis. And I'm going to talk about peripheral arterial disease. So the clinical clues help us in differentiating them. And there's an interesting score that it's easy to use, and I think that like the test characteristics are not perfect, right? So it has sensitivity on the 80s and specificity on the 70s. If you have a lower threshold, and then if you cut off at 5, you're more sensitive, so your sensitivity goes up to 90, but then you're less specific. But it's a score that could help you, and I think the nice is that it tells you like what can you do if you have this score. So you calculate, so it's asymmetry, leukocytosis, tachycardia, age more than 70. So if your score is 0 to 2, so then most likely you don't have cellulitis and you should reassess. If your score is 3 to 4, you should consider a dermatology consult in assisting with the diagnosis. And if your score is 5, 6, or 7, you should treat for cellulitis. What I found interesting is that if you have asymmetry, you get 3 points. So asymmetric edema is like very important to diagnose cellulitis. And if you don't have asymmetry, so even if you are tachycardic, if you have a white count, and if you have an age of 70, you can only make it up to 4. So if it's symmetric, if you have both legs that are red, very likely is not really cellulitis. So just some pictures just to show you that it can actually look like cellulitis. So in venous stasis dermatitis, patients come with same ill-defined bilateral pitting edema, lower extremities, erythema, hyperpigmentation, and desquamation. So this is unilateral venous stasis dermatitis. This is bilateral venous stasis dermatitis. It can look like cellulitis, like very easily, because it's red, it's swollen. Then this is the other one that I was mentioning that we don't think about frequently. So this sclerosing paniculitis is a type of like late stage of venous stasis, and in the acute phase, it can look like cellulitis. It can be very painful. It can be red, it can be swollen, it can have a weeping, and you can see that bilateral is the other characteristic. And lastly, the other one that I want to touch briefly on is peripheral arterial disease and dependent rubor. There's a say, I think, in the IT world, is that if you haven't elevated a leg with cellulitis, then you haven't examined it, because as you can see here in this patient, so this is our patient actually from the case. So when he stood up, his legs got very red and erythematous. And then on elevation, when he was flat in the bed, this is after elevation of the right leg, so his erythema improved. So this is called dependent rubor. So erythema disappears after elevating the leg, and this can occur in patients with peripheral arterial disease. This is actually what our patient had. So this is our patient. He's admitted to the hospital. You're giving the good old cefazolin, 2 grams, 2 grams, 2 grams. You have here your fever curve, like no fevers. And then after, we actually stopped checking his white count because he never developed a white count. What he did have was a lot of pain. He did have a lot of pain. So he was taking Tylenol, he was taking Oxy, and then nothing was controlling his pain. So very uncontrolled pain and no systemic symptoms of cellulitis, which made us every day question ourselves, okay, is this cellulitis or are we doing something else? We asked vascular to see the patient because he had decreased pulses, and they did Dopplers. They said no indication for any further testing. This is just post-phlebitic syndrome and cellulitis, but pain that doesn't resolve is really something that should be concerning. So we decided to get some imaging. So he had unresolving pain. He got a CTA of bilateral lower extremities, and he had an occluded right popliteal artery, likely secondary to chronic PAD, as patient was endorsing pain for months. So his pain was sort of like subacute or chronic, and they said that they could not rule out embolic event. And the patient went to the OR 3 times. So the first time he went for an angiogram, and I think he got a stent. The second time he went for a bypass, and the third time he went for amputation of these 2 toes. So he actually had gangrene due to peripheral arterial disease, and so he really didn't have cellulitis. So he really had really bad peripheral arterial disease that is not acute. This is not a cold limb. It's not an embolus that it goes to the leg and causes acute limb ischemia. This is called chronic limb-threatening ischemia. So it's like the peripheral arterial disease is so bad that your circulation is so compromised, and this is not over a matter of hours, it's over a matter of days. And I think that, yeah, so over the course of the days that he was admitted, there was no change in his clinical status. So it's a really unfortunate case, and it brings up some teaching points. So cellulitis is rarely bilateral. Stasis dermatitis is the most common mimic of cellulitis. If you have erythema due to true cellulitis, it doesn't disappear when you elevate the leg. Patients with cellulitis can often have systemic symptoms such as fever, leukocytosis, tachycardia. If you have a chronic course, it points towards a different diagnosis. And if you have some chronic changes, plaques, dark pigmentation, this could point to a chronic disease rather than cellulitis. So my take-home point number 1 is whenever you get an admission for cellulitis, always ask yourself, is this true cellulitis, or can it be an alternative diagnosis? Any questions so far? Nope. All right, I think we're good with time. So we're gonna do case 2. This is another patient that's that was admitted to MSW, 88-year-old male, A-flutter, DVT, an Eliquis, Parkinson's, prostate cancer, dementia, ANO times 1 at baseline, brought in by EMS for fever. The visiting doctor noted that he was febrile. He had some upper respiratory symptoms, had some heavy breathing in the field, and he was found to be lethargic, so encephalopathy. On arrival at the ED, The patient was tachy, regular rhythm. He met sepsis criteria. A broad workup was done. They noted the left lower extremity that we saw, erythema, swelling, his toes purple, bilateral peripheral pulses were palpable, his ANO times 0. His vitals, he was tachy, borderline low blood pressure, low grade temp, WBC of 14, and lactates, and he was given vancomycin and cefepime as brought for sepsis. So I'm gonna go back to his picture just so everyone takes a look. Somewhat similar admission, like left right leg, same as our other patient, but a little bit more symptomatic. So chiefs, if you could help me out with the questions. So if anyone could take question number 1.
So can you help us out?
Yeah, of course. Can you hear me, guys?
Yeah.
Yeah, so for first question, I think it depends if it's purulent or not. If it's not purulent, then we think about the streptococcus mainly. With purulent cellulitis, we can think of Staphylococcus aureus. And which patients should get blood cultures? I mean, if we're thinking cellulitis, I think basically all patients, but I'm not sure about this one.
Good, perfect. Yep, thank you. And we can go to question number 2, unless anyone else has any comments for the question number 1, so we can have someone answer question 2.
Mary Louise.
Yeah, I'm not sure if Salvador already touched on this, how we classify. I thought like it was purulent or non-purulent. And I guess that would give you like if people can be, for example, treated with oral antibiotics or they need admission for IV antibiotics.
Okay. Okay, so it's purulent and non-purulent, and then also you have to decide like oral versus IV antibiotics. What makes you make that clinical decision between oral or IV?
So basically,
It's for anyone. Yeah, it's not only for you.
And also, guys, you can type it in the chat.
Yep. Who gets PO and who gets IV antibiotics?
Well, obviously, if someone is like MPO for other reasons, they can't get oral, or they're altered, they can't, there might be an aspiration risk. So
Yep.
So with the systemic signs of toxicity, fever, tachycardia, hypotension, so more towards septic picture, people should get IV.
And Nadim is asking how extensive the cellulitis is.
Diabetic more likely to get IV antibiotics.
Sorry, could you repeat that? Oh, it's okay. Okay, yep. So you can classify them by like purulent and non-purulent, as Marie was saying very well. And that guides the type of antibiotics that we give. And then clinically, we also can assess how sick the patients are, right? Some patients are adequate for outpatient treatment with PO antibiotics. And then some patients need IV antibiotics and can do general medicine. Some patients need a more intense treatment in the ICU. So that helps us to guide the treatment. And question number 3.
Kirti, can you help us with the question number 3? And anyone else can jump in at any time.
So risk factors, I guess, like IV drug abuse history, HIV infections, recent hospitalization or any recent surgery, maybe any prior antibiotic use, if we can have like a MRSA infection.
Okay, yep, very good. I see here colonization, immunocompromised, sports, nursing homes. Very good. Yep, excellent. Hemodialysis or MRSA. Yeah, very good. Okay, yeah, so we're gonna touch briefly upon those points and that. So as Salvador was saying, that's pretty much the rule. That's of course, nothing is absolute in medicine, right? So non-purulent cellulitis, the most correct one is non-purulent cellulitis, beta hemolytic strep, more than staph. So when you have like no abscess, no purulent drainage, no vesicles, you think of strep, and less in staph. You can also have staph. And if you have purulent cellulitis, so if you have any abscess, collection, purulent drainage, you think of staph much more than strep. And this is what guides your treatment. To the question about the blood cultures, so actually, so cellulitis, interestingly, is an infection that really we treat empirically, and that most of the time, like 85% or 90% of the time, we will not isolate a bug. We'll not know if we're treating strep, we'll not know if we're treating staph, unless the patient is very sick. And this is from, I think, a systematic review that is recent. So these are the pretest probability of bacteremia in common clinical conditions. So very low, 5%. So we see here that uncomplicated cellulitis, including periorbital cellulitis, the pretest probability of bacteremia is actually very low, less than 10%. And if you have a cellulitis in patients with severe comorbidities, the risk of true bacteremia is 10 to less than 20%. So it's actually very, very low. So maybe we could argue that if the patient has uncomplicated cellulitis, even if the patient is admitted to the hospital, probably they shouldn't get blood cultures. It should be okay if they don't get blood cultures. If they have moderate comorbidities or moderate disease, probably they can get. And then the patients that are septic and the patients, I wanted to highlight this one because this is an interesting thing, and I'm sure you've heard about this from our ID faculty, that rigors or shaking chills are a good predictor of bacteremia. As if the patient has an infection and they have rigors, they're rigoring in front of you, they are very likely to have bacteremia. This is like rigors rather than just feeling cold. Then of course, high probability of bacteremia, we know, septic shock, catheter infections, meningitis. So this table is interesting, and it tells us that, for example, community-acquired pneumonia, really not as much risk of bacteremia. I think we a little bit of overdo it. So most of the time, we will not get our bug. Who needs blood cultures? With patients with moderate and severe disease and the following. Malignancy on chemotherapy, so everyone that's admitted to 9A, neutropenia, everyone that's admitted to 9A, severe cell-mediated immunodeficiency, immersion injuries, animal bites, and I think that here I'm missing IV drug use. So if you have IV drug use, you probably should get blood cultures because you have a high likelihood of staph and of finding your bug. So in terms of the treatment, we go back to our classifications. So purulent and non-purulent, abscess and purulent drainage is the one that we're going to see in the hospital. And then in non-purulent, we're going to see cellulitis and neck fash in the hospital. So this helps. So non-purulent, we said is mostly strep. Purulent, we said is mostly staph. Again, back to that. And now, how severe is the disease? And this will help us guide our management. So mild, 0 signs of systemic infection. So these patients I'm not going to touch upon because I don't see them in the hospital, but you should absolutely know them for the clinic. So no signs of systemic infection. They can get PO antibiotics and be followed up as an outpatient. Moderate disease is anyone that meets 2 SIRS criteria. And this is interesting. And when I was reading upon it, I found this interesting because if you have cellulitis, a red leg and 2 SIRS criteria, that patient has sepsis. Technically has met the criteria for sepsis: fever, hypothermia, tachycardia, WBC count. So they are moderate disease. And then severe disease is sepsis plus hypotension, septic shock, immune compromise, or very rapid disease progression. So we classified in mild, moderate, and severe. And I'm not going to touch on the mild. So for non-purulent cellulitis, MRSA coverage is not indicated. So we spoke about that non-purulent. Most of the time, it will be strep, and less so, it will be staph. And if you have a staph infection, it will probably be sensitive. So if you have a patient in the outpatient or with moderate disease with non-purulent cellulitis, treating for, so this study looked at patients with simple cellulitis. There was no significant rate in cure rate if you gave only cephalexin, or if you gave cephalexin and Bactrim, which would treat MRSA. So if you have uncomplicated cellulitis, MRSA coverage is absolutely not needed. And we go to who actually needs MRSA coverage, and these are risk factors. So a history of MRSA infection. So go back to your cultures and check if the patient has been colonized or they have had MRSA. Smoking, illegal drugs, injection drug use, recent incarceration, contact sports, frequent visits to bars. So pretty much everyone in New York. HIV infection, recent antibiotic use, recent hospitalization, hemodialysis, as they said, close contact with known and suspected MRSA infection. Yep. So this is from a really good review, and I'll send it to the chief so you can distribute it. So for non-purulent cellulitis, patients that are admitted to the hospital, so it's moderate disease, so you should cover with 1 antibiotic, cefazolin, ceftriaxone, or Clinda. The star is here for penicillin allergy. Only if you have a really bad penicillin allergy, you should be using Clinda. And for purulent, then you're thinking, okay, this is staph, and then you divide it further. So if my patient has risk factors for MRSA, then you want to do vancomycin or Clinda. And if the patient has no risk factors for MRSA, then you don't need vancomycin. You can do cefazolin, oxacillin, nafcillin, or Clinda. Or you could do Clinda to everyone and just cover everything. But no, we don't like that. So if you have risk factors for MRSA, then vanc or not cefazolin or ceftriaxone. So one take-home point from this is that for moderate disease, I think that the best practice and some antibiotic stewardship is to use 1 antibiotic only. And then for severe disease, then that's a completely different thing. So we're talking about a patient that's septic, immunocompromised, hypotensive, or rapidly progressive disease. You want to cover MRSA, and you want to consider necrotizing fasciitis in your differential. So you want to add anaerobic coverage with piptazo or meropenem, and then you want to consider surgical assessment. Any questions up until this point before we go to the last case? So last case, case 3. So we first saw a case of bilateral cellulitis, quote unquote, but not cellulitis. We saw the second case was actually cellulitis, typical and admitted, and this is the third case. This is not the patient's picture. The 44-year-old male, HIV, anxiety, depression. He came in with a week of left thigh pain and decreased mobility due to pain. He developed a wound in his right buttock, which is like, okay, he had a wound in the right buttock, and then he comes in with left thigh pain, and this is a picture of his right buttock. That's what I could find on media in Epic. Sorry, we didn't take pictures of the leg. He has been sleeping, laying and sitting mostly on the left side. The pain has been worsening, but his legs feel funny. He had issues ambulating. He's using some creams and Chinese herbs, medicine, and has some fever, and he decided to come to the ED. So in the ED, he's tachy, normotensive, he was febrile, WBC count 22, hemoglobin of 11, sodium 131, ESR 120, CRP 400, glucose normal or less than 180, and lactate 2. So if you could help me, Julia, answering the questions, and let me know if we're running too late.
No, I think we have still like maybe some minutes. Adrian, do you want to help us with the first question? I don't know if you're talking, but we cannot hear you. I think you're muted. Okay. Maybe then Debbie and Martin.
See here, they text.
So if upon palpation of the extremity or the leg that has the inflammation, if you feel any crepitations, then you may suspect a necrotizing soft tissue infection.
Absolutely. Anything else? I see here pain out of proportion to physical exam findings. Yes. Anything else? Fever. Anything else? Rapid progression. Absolutely. Poorly defined margins. Yep. Okay, very good. The next question.
Bruno.
Is there any labs that you think that are helpful, or any scoring systems that can aid in the diagnosis?
So I think for the labs, mostly the labs we would order for a patient with severe infection, such as VMP, especially to see how the renal function going. Also CBC to check the cell count. And then also blood cultures, I think would be worth it in this case. And about the scoring systems, unfortunately, I do not know any for necrotizing soft tissue infection.
Yep, no worries. So lactate, if concerned for sepsis, very good. Okay. You can also get a CPK if you're thinking of muscle involvement, can go high as well. And then third question, which antibiotics would initiate? And I think that we went over this.
Who wants to answer this
Type them in chat. Which antibiotics do you think would initiate? So A plus B, Ciclinda. Yeah, very good. Any other thoughts?
Toxic, you're saying.
Flagyl. Only Flagyl, only doxy, imipenem. Okay. Plus gram positive. Okay. Good. So write both. Yeah. Banks, ceftriaxone. Good. then gram-positive, negative, and anaerobes. Yeah, very good. But what antibiotics? Sulbactam for neck fash, carbapenem, sulbactam and flagyl, cefepime for coverage of Pseudomonas. Okay. Good. Good. So let us go over this. So this is our patient. So very different fever curve. So he was admitted to medicine. He was started on ampicillin and sulbactam. So he kept spiking temps, 38, 38.5 over days. He had a white count from admission and it never downtrended. So he kept being high. And surgery was following him because of the symptoms, the uncontrolled fever, the uncontrolled white count. And then he initially got imaging, a CT in the ED that didn't show any concerning findings. But then because he didn't get better, so he got an MRI of the leg. And I'm not a radiologist, and I don't expect anyone here to be able to read it. All I can know, this is the left leg. This looks abnormal. So I know that this is a bone. I know that this is a muscle, and I know that this is something that looks bad. So he did have muscle fascia involvement on the left leg. And interestingly, so his skin was actually not very red. It was not very red, not very swollen. He was swollen, but it wasn't very red. So what happened, I think, is that, and this is what happens with neck fash, is that because your infection is in the deep tissues, and that's what they say, pain out of proportion for clinical findings. So if you have a very red leg, you're talking about the skin and the subcutaneous tissue. But if you have a lot of pain but almost no skin involvement, then you're talking about deep tissues. So yeah, he had a really bad infection. He went to the OR. He got an incision of 15 centimeters above his knee, all compartments released with some murky fluid expressed from the inner thigh that tracked up to the buttock. And he was irrigated with saline. And this is the wound after the surgery. And he took a long time to heal. He went to the OR multiple times for washout. So really bad infection. So findings that suggest neck fash. Everyone said it: pain out of proportion, edema induration, biolaceous, bullae, mottled skin, anesthesia, crepitus, rapid progression, failure to respond to initial antibiotics, and I would highlight this one. If your patient's not responding in 2 or 3 days of appropriate treatment, systemic toxicity, multi-organ failure. So in terms of scoring, there's two that can be useful. Really, this is a clinical diagnosis, but this is a prediction model, and they saw that if you have 2 lab abnormalities, so if you have a WBC count more than 15, if you have hyponatremia, it could suggest neck fash. So it's sensitive up to 90%, but it's not very specific. So I think a lot of patients with cellulitis can have this, can have a leukocytosis and hyponatremia. So think about it. They might not have neck fash, but keep it in the back of your minds. And then someone mentioned in the chat the LRI neck, I think that's how you say it. So it's a score that has a lot of pointers. It has ESR, or the CRP, I'm sorry. And if you calculate it, it has a sensitivity of 90 and a good specificity. Positive likelihood ratio of 19 and a negative likelihood ratio of very low. So if you have a positive score, it doesn't mean that your patient has neck fash, but you should keep it in the back of your mind. So if you see, actually our patient met both of those criteria. So he had hyponatremia, he had a high white count, and then his score was above 8 and the cutoff is 6. So yeah, so those tools are just adjuncts, but then history of physical examination and early asking for help is what you do. So pretty much if you have swelling, erythema, and pain, if you have a history of trauma, bone fracture, GU and GI surgery is a risk factor, childbirth, GYN procedure, and if you have systemic signs, tachycardia, hypotension, CPK, high CRP, LRI neck of more than 6, then you get your imaging, and then you are mostly speaking about necrotizing soft tissue infections. And there's multiple types that go beyond the topic of this talk. So I think, but in this case, covering broadly, you want to cover your gram-positive, so strep staph. You want to cover MRSA, so you want to do vancomycin, and you also want to cover anaerobic. So I think SOSIN would be a good choice where you could do, because it would cover Pseudomonas, but Vanc, Cefepime flagell would do it as well, or vancomycin or vancomycin. And then Clinda, that was mentioned, it's a very good one. And this is specifically just for Clostridium. So once you isolate Clostridium, then you treat with penicillin and Clinda. So that's all I have. Some take-home points. So first, diagnosis and doubt of a diagnosis of cellulitis. Distinguish true cellulitis from its many imitators. Is critical. So if you're not diagnosing correctly, how can you treat correctly? So then second point number 2, the majority of cellulitis is caused by staph and beta hemolytic strep. See how severely sick is the patient to determine the appropriate initial management. And as much as possible, if your patient is not severely compromised, use one antibiotic. And then third is have a high index of suspicion for neck fash. Get a broad coverage, get ID, and get surgery on board soon. So I think that's it. Thank you, guys.
Thank you, Dr. Hernandez. Does anyone have any questions? We just have maybe 1 minute for questions. What antibiotic was used in this specific patient? Noble was asking.
So he was covered broadly with Vanc and SOSIN. He actually ended up growing MRSA, so it was a MRSA infection. So I think he was just switched to vancomycin, and then he was continued on PR.